share the screen first.
Good morning, everyone. My name is Zarif Shahenk. I'm a neuromuscular disease specialist and investigator at the Center of Gene Therapy, Nationwide Children's Hospital, Columbus, Ohio, and I'm very pleased to participate in CMTA Patient and Research Summit this year, and I thank the organizers for this opportunity. I'd like to start with a brief overview of CMT neuropathies in general, just to emphasize certain important features. CMT neuropathies are the most common inherited neurologic disorder with a marked variability at the age of onset from congenital to 70 years or more, mostly during the first and third decades. Severity is also variable from asymptomatic to low functional disability and to severe forms with loss of autonomy. There are associated signs, particularly in rare forms, such as deafness, tremors, pyramidal signs, diaphragm palsy, vocal cord palsy, and most importantly, there is a marked genetic heterogeneity, more than 100 identified genes corresponding to CMT subtypes. The classification of CMT subtypes are still evolving. Before the days of gene testing, that is, to be exact, 1992, the year the gene defect in CMT1A was discovered, the classification of hereditary neuropathies was according to electrophysiology and the pattern of inheritance. Here, I deliberately chose this table from 2014 just to emphasize that several pages are needed to have an up-to-date list of all CMT causing genes. This table shows only about 1/4 of all the reported disease-causing genes. With advanced recent technologies, new generation sequencing of DNA is not only enabling impressive scientific achievements and discovery of new CMT genes, but also providing genetic diagnosis to CMT patients much faster. However, underlying the mechanisms of how these genes are causing damage to nerves are still challenging. What needs to be emphasized here is that regardless of the gene, majority of CMT patients present with what we call classic CMT phenotype or clinical features, that is a length-dependent distal axon disease. That means that the longest axons and their distal segments, meaning far away from the cell body, will show the signs of disease, and as a result of that, the initial symptoms will be deformities in the feet or atrophy of the anterior and posterior leg compartments. Then the hand symptoms will begin as atrophy and weakness of the intrinsic hand muscles or the forearm muscles. As I mentioned earlier, CMT is the most common inherited condition. What makes the peripheral nerves vulnerable to genetic disorders? First of all, the severity of neuropathy mild, moderate, or severe as a reflection of patient's disability directly correlates with the degree of axonal loss. What makes the neurons vulnerable to disease process is related to its unique morphology of nerve cell and oxoplasmic transport. As illustrated in this cartoon, uh, neurons, first of all, are quite amazing cells made once, last a lifetime, has a cell body and its extension uh, is quite long. Here, the entire extension is illustrated as a 3.5 loop, actually equivalent to several thousand loops. That means that all the proteins synthesized in the cell body has to be transported down to the ends of the axon for its survival, because protein synthesis mostly takes place in the cell body where the nucleus is. Neurons have quite complicated and sophisticated different kind of cellular mechanisms. One of them is oxoplasmic transport. Proteins made in the cell body has to be loaded to a system, and this cargo has to be moved along these microtubules, and at the end of the nerve and the synaptic terminal, there are also sophisticated, complicated events takes place. Membrane-bound vesicles are excreted, and certain substances are uh, taken into the cell, such as growth factors, and there are interactions between these vesicular organelles, and then this substance has to be again loaded back to be transported to the cell body for a degradative process. So, as illustrated in this cartoon, the anterograde transport and retrograde transport events require different kinds of cellular motor proteins and very many associated proteins, meaning that there are very complicated, numerous proteins, genes are involved for all these events to take place in a proper manner, and any abnormality along the way can potentially affect the axon in a negative way and makes it vulnerable to disease processes. The second vulnerability comes from axon dependence on Schwann cell for survival, in a way axon hooked on myelin. Schwann cells cover the axon, not only serves as an insulating substance, so the conduction will be faster along the axon, but also provide nutrient substances to the axon. It's essential for survival of the axon as a function like clearing up the axonal damage and organelles. So the axon's viability, especially parts way away from the cell, depends on healthy Schwann cells. If I tell you that each Schwann cell covers about 1/10 millimeter length of the axon, you could imagine that zillions of these Schwann cells has to be lined along the axon, function properly to provide survival to the axon and protect it. With this information, let's have a look at CMT1A and discuss what it means from the viewpoint of pathobiology. What is CMT1A? It is a myelin disease because the genetic mutation is in the Schwann cells. It's due to PMP22 duplication. Electrophysiology viewpoint, it is CMT type 1, demyelinating. But As far as clinical presentation is concerned, it is an axonal disease, a distal non-terminal axonal disease, because of the dysfunctional Schwann cells, their inability to provide the support for survival to these distal parts of the axons results in secondary axonal damage. And we know that the clinical severity in CMT1A directly correlates with the degree of axonal loss. Even though individuals with CMT1A, when they were born, all this entire length of the axon covered with mutant Schwann cells, the disease manifestation starts later on, and this is due to the axonal loss. When it reaches to a threshold, then the patient starts to show signs of it, such as ankle rolling or twisting episodes. What about the other commonly associated signs of symptoms other than the classic CMT clinical presentation or dying back neuropathy? It has been recognized for quite some time that careful patient evaluation reveals other signs of symptoms associated with CMT. Here, it's only common forms of these conditions are listed. In CMT1, the demyelinating forms, it's been reported that 88 of the patients had at least one added feature, with 65% having two or more other manifestations. Here's the list of CMT subtypes with increased prevalence of certain conditions. For scoliosis, other spine and skeletal deformities and joint issues, I listed these CMT subtypes here. Genes and related subtypes are grouped, color-coded. When we look at here, we can appreciate that those subtypes with mutations in myelin genes or vesicular membrane trafficking related genes are more commonly manifesting these added plus symptoms and signs. And among them, the yellow-coded colored ones, those with autosomal recessive ones, they are presenting these scoliosis and other spine skeletal deformities, joint issues more severely. And among them here, CMT4C, CMT2B, have more severe manifestations than others. Also CMT2A, the one with hysterics, and those due to the TRPV4 mutations, CMT2C also shows severe skeletal spine deformities compared to others. Breathing-related issues and respiratory dysfunction is more common again in CMT4C and CMT4J. These are the autosomal recessive forms. Vocal cord paralysis in 4A, and these are less common in CMT1, more common in the autosomal recessive forms. Obstructive sleep apnea is more common in CMT1, and restless leg syndrome is more common in the axonal form than the myelinating forms. Based on this information, it appears that severity of CMT neuropathy plus clinical features are reflection of the underlying gene defect induced impaired cellular function and severity of axonal loss. Here, these gene defects are grouped according to their cellular function, and where these are more critical in different cellular events, such as these vesicular trafficking is more dominantly critical in cell body nerve terminal events, and the myelin genes are grouped here. The more severe is the genetic defect causing Schwann cell dysfunction, the more severe axonal neuropathy will take place. Intercellular transport trafficking related genes and mitochondria grouped here. That is essential for oxoplasmic transport events. tRNA synthetases are obviously important for protein synthesis in the cell body, and the mitochondria-related genes, of course, is important for all cellular functions, cell body, axon terminal, oxoplasmic transport, and also in the muscle. So among these cellular events, those with the high energy requiring ones takes place in the cell body, oxoplasmic transport for organelle translocation, and nerve terminal events at neuromuscular junction. And of course, healthy mitochondria is essential for these functions. The subtype CMT2A actually is the best example for classic CMT plus features um, resulting from mitofuscin gene mutations. This protein is critical, involved in the fusion of mitochondria, where two mitochondria joins with each other. And this event is stimulated by energy demand and stress. The opposite event, fission, is modulated by other proteins, and GDAP1 is one of them. And so together, fusion and fission events are important for facilitating the mitochondrial quality control. And the phenotype resulting from these mutations are quite variable and present with a very wide spectrum from the classic CMT phenotype is illustrated here, the typical ones, similar to a CMT1A patient, for example, to highly complex, different manifestations. Certain mutations cause more of an optic atrophy or cognitive impairment. Some mutations are together causing with both peripheral nervous system and long track signs in the central nervous system, and the signs of brisk reflexes, or what we call upper motor neuron signs. Babinski sign can be elicited during the exam from these patients. The studies in CMT to the mouse model serves as an example showing clinical features correlating with underlying gene defect related impaired cellular function. In this animal model, the axons are small, myelin is thin. There's dwindling of the nerve terminal as initial site of pathology. Because of this feature, actually, we can now explain some patients presenting with upper extremity weakness, hand involvement, thirst, rather than the classic CMT phenotype. that starts in the lower extremity distal muscles. In addition, the muscle in this model, small, having muscle fibers much smaller fiber diameter, and there is also a late onset myopathy uh, showing necrosis regeneration as a primary myopathic event with mitochondria abnormalities with decreased mitochondrial protein expression. So all these signs and symptoms and findings that we see in GAR's mouse model is a reflection of globally decreased protein expression. In our preclinical studies with anti-3 gene therapy, we were actually able to attenuate significantly some of these features of this animal model. The treatment resulted in increased myelin thickness, improved neuromuscular junction connectivity, and also increased the muscle fiber diameter. I want to finish with this slide as great references for physicians taking care of CMT patients. The clinical practice guidelines for CMT neuropathy plus conditions, pediatric CMT best practice guidelines consortium developed evidence and consensus-based recommendations for clinical management of children and adolescents with CMT, just published recently, and specific guidance on orthopedic management of joint and spine deformity is also available as referenced by the European Neuromuscular Center workshop report and the consensus statement on the surgical management of foot and ankle deformity in CMT. Finally, here's our center of excellence listed in CMT1A webpage, as all other centers in other states with telephone number, and we will be happy to help to find the best healthcare team if it is available for those to get a center of excellence. Thank you. What? The question is, osteoporosis, osteopenia more common in CMT1. I would not say it's more common in CMT1. It is actually more common in mutation or conditions. The bone abnormality is more common in the subtype secondary to TRPV4. I would say that the answer is it's yes, at age 40 is rather unusual, but I wouldn't say it's more common in CMT1. There may be possibly other causes, and my recommendation that it needs to be investigated by subspecialists in the area. Autonomic nervous system, autonomic nerve involvement, I can start saying that is not common in CMT1 in general, but later on it may come to the picture. Those subtypes secondary to mitochondria abnormalities may have these symptoms more, um, and usually uh, uh, mild abnormalities as skin color changes in those with hereditary sensory neuropathies, and more severe ones in the hereditary sensory autonomic neuropathy group will have more autonomic nervous system abnormalities. But just like myelinated fibers, generally speaking, CMT1 1A in particular involves the large diameter fibers first, but as disease progresses, it is also possible that autonomic fibers will also be affected. But generally speaking, those with secondary to mitochondrial abnormalities or mitochondria affected secondarily during the disease process, autonomic nervous system abnormalities can occur. It's less common than the typical presentation of motor and sensory abnormalities. Joint contracture is tightening of the joint. Most commonly, as we see that as heel cord tightening. Um, This could be due to an imbalance between the involvement of one compartment muscles compared to the other one. For example, if anterior compartment muscle in the foot affected more severely, that is the one actually makes the foot go up, the dorsiflexion. And if the posterior compartment muscles are more stronger, this imbalance can result in tightening of this joint and contracture. The imbalance, weakness, or imbalance between two joints can manifest as joint contracture. Uh, Unfortunately, I believe it is not well studied, although it needs to be studied more extensively. Um, Again, if autonomic nerve fibers are affected, then as a result of that, there could be some bowel and gut issues and constipation and so forth. And it's an area that definitely needs more attention and research in the future. I'm afraid I'm not going to be able to give an answer to this question. I need to look into that. I'm sorry. Um, I'm not aware of this association. That doesn't mean it's not. If it is um, reported, I'm not aware of it. Hello, Emma. Unfortunately, I don't have anything at hand, but I'll be happy to look into that and try to give you more information. If you choose to contact me, I'll be happy to do that. Are the PrEP protocols for colonoscopy safe for people? I won't be able to answer this question again, but uh, I'll be I'll be happy to look into that and try to get back to you if you contact us. No, that's not direct indication that you have the autonomic system affected. Hmm?
Hello, Dr. Sahenk. Thank you so much. It's absolutely wonderful to listen to you speak today. I think we've had so many questions coming in. I think we've got 1 more minute, so I'll just let you answer the last one that's come up there.
Uh, I have I have heard some talk about swallowing issues with something. I do know that. I doubt very much that the hiatal hernia is due to CMT. It could be an isolated condition. I think uh, the that's all I can say. The hiatus hernia, I have not. I'm not aware of that. It could be related to CMT1A.
Thank you. Oh, we've got one last one. We'll make that the last one.
No, the heart. Not that anyone knows that heart is affected by CMT1B.
Wonderful. Thank you ever so much, Dr. Sahenk.
Thank you.
We've got 140 and rising people in this session, so it just shows how wonderful it's been for everybody to hear from you. Thank you for all of that information and for answering everyone's questions so generously. It's been really great listening to you speak today. And thank you to everyone. And thank you to everyone who's joined the session. We're just finishing off this session now on neurology, and everybody will just have a 5-minute break before we go on into your next options, which is either physical therapy or occupational therapy. So if everybody wants to head back to the lounge, you can join one of the chat tables if you want to, or you can just have a short break before the session start again at 11:15. Thank you ever so much again, Dr. Sahenk.
Thank you.
Thank you.